Good evening, everyone. Welcome to the next episode of Pathagonia. So tonight, in honor of the first rain that we've had in a while here in Texas, the background music is going to be the relaxing sounds of rain, which hopefully you enjoy. I know for me, it reminds me of a recent trip my wife and I took to Costa Rica into the rainforest. And yeah, so it can be somewhat calming background noise. But tonight I just wanted to go through the cervical cytology section from Kurt's notes. As I mentioned last time, I'm gearing up for my cytopathology rotation next week. So this is good review for me, and I haven't had a lot of cyto rotations, so I'm not an expert, so I'm reviewing this and learning it myself as well. But I thought if I can capture this review session and if anyone else can benefit from it, then I might as well record it. So first we're going to go through some cell types. So of course these are going to be specimens that you see when you're looking at a pap smear, so cervical cells. And these first cells are superficial cells, which, as the name would suggest, are more superficially located, and they're going to have a small pycnotic nucleus with abundant cytoplasm. They're often pink, but they can be blue, and if you see superficial cells, that's going to indicate abundant estrogen is present. The next cell up, we have intermediate cells. So just on first glance, you can see that the nuclei are slightly larger than the superficial cells. There's typically abundant blue cytoplasm and larger round to oval nuclei. And the intermediate cells are going to be very important to recognize, as those are often going to be the cells that we're going to use to reference other cells to see if we're dealing with an ascus or an L-cell potentially, based on the size of the intermediate cell nucleus. Next up, we've got the basal or the parabasal cell, and that has minimal cytoplasm with a round to oval nuclei. So for me, this can kind of be a tricky cell, because I guess at first glance, the first thing that stands out to me, it kind of looks, you see a high N-to-C ratio, so that could be slightly concerning, but these are not anything necessarily to be concerned of. And you could see this with in atrophy or in low estrogen, in settings of low estrogen. And next up, we've got endocervical cells. So important to be able to recognize these. We've got uniform columnar cells that are polar with the round nucleus at one end. So we've got our nucleus here and then the cytoplasm on this side. And I've heard this as like a picket fence. And obviously when they're arranged in flat sheets, they can have this honeycomb appearance. So honeycomb and palisading or picket fence commonly associate that with endocervical cells. And the majority of the cytoplasm is occupied by mucin. So endocervical cells are going to have a lot more cytoplasm than endometrial cells, which is our next cell type. So endometrial cells, for me, I think of these as like a 3D ball, but they're going to be small with a high N-to-C ratio, and it's almost all nucleus. So as the ratio would suggest, a lot less cytoplasm. And the nucleus is about the same size as an intermediate cell nucleus. And these can be found in large groups, and they're going to be something that you want to report. This says if over 50. I've also heard if over 45, you're going to want to report the presence of endometrial cells. So just look that up and confirm that, just so you have the correct information. Pap smear adequacy criteria. So the minimum number of well-visualized squamous cells for adequacy. So the way I remember this, you have your liquid-based preparation and your conventional prep. So the most common liquid, and the theme tonight, since it's raining, the most common liquid we often think of is water. And water, the word water has 5 letters. So I remember water, 5,000 cells. So liquid-based preparation, you need 5,000 cells for adequacy, and then for conventional prep, you need 8,000 to 12,000 cells. And another thing to be mindful of when you're looking at a pap smear is if there's elements that are obscuring more than 75% of the epithelial cells, that's going to be unsatisfactory as you're not really able to assess the specimen well enough for the patient. So a quality indicator can be the presence of 10 or more endocervical cells or squamous metaplastic cells. And it can be reported but not required to be satisfactory for evaluation. And any specimen with abnormal cells is considered adequate and should be reported, regardless of the amount that's obscured or if the number of cells. So if you have cells that are atypical or abnormal, could be malignant, that's going to be adequate and going to be something that you're going to assess. Moving on. So first up, we've got low-grade squamous intraepithelial lesion, or LSIL. So this is defined by mature keratinocytes with lots of cytoplasm and enlarged nuclei that are 3 times the normal intermediate cell nucleus. So if we had an intermediate cell nucleus here, we would want to be able to fit 3 of those nuclei into an LSIL nucleus, if that makes sense. Also, for LSIL, you can see nuclear membrane irregularities, hyperchromasia, or they can be raisonoid in appearance. And optional, you can have perinuclear halos or coilocytes, which we see like a classic coilocyte here, but you don't necessarily have to see the coilocytosis or coilocytes to call LSIL. If you have the enlarged nuclei that are 3 or more times the size of the intermediate cell nuclei, then you can still call LSIL without seeing coilocytes. And in LSIL, you can also often have multinucleation. LSIL is caused by high and low risk HPV and may regress spontaneously. And another diagnosis is ascus that I mentioned earlier. So atypical squamous cells of undetermined significance. And this is going to be, you have some findings of LSIL or some findings that are atypical but not quite enough to get to LSIL. And that's this other category or this other bucket that we have that's called ascus. This can be either quantitative or qualitative. So you're assessing the number of cells that you're seeing and also the quality of each nucleus. And for ascus, you're going to have 2.5 to 3 times the size of the nucleus is going to be 2.5 to 3 times the size of an intermediate cell. But for LSIL, as I mentioned earlier, it's going to be 3 or more times as large as an intermediate cell nucleus. So for HSIL, or high-grade squamous intraepithelial lesion, these are immature keratinocytes with minimal cytoplasm. So mostly nucleus, you have a very high end-to-C ratio, and you're going to have markedly irregular nuclear contours. So you can see these nuclear contours down here are very irregular. They're not smooth and uniform. They're very irregular and clumpy. And as mentioned, you're going to have the irregular chromatin and or hyperchromasia. So very dark, irregular cells, high end-to-C ratio. You can see them individually or you can see them in groups altogether. And you have, again, let's say you have some findings but not quite enough. You're going to want to consider the category of ASK-H, or atypical squamous cells, and you cannot exclude HSIL. And again, that's going to be a quantitative and a qualitative assessment. And really what we're trying to do is just get the best diagnosis for our patients and get them the best management. That's ultimately what our job is. Next up, we've got squamous cell carcinoma. I actually just had this on a quiz today and I got it correct. So for squamous cell carcinoma, you're going to have non-keratinizing squamous cell carcinoma that may look like HSIL or have similar findings. And clues to invasion could be you could have necrotic debris or tumor diathesis in the background with prominent nucleoli. And then you can have these tadpole or snake cells that are very irregularly shaped like this. And they can be prominently orangeophilic or keratinizing, as we see here, this orange. And just because you see some orange material on a pap doesn't necessarily mean it's squamous cell carcinoma. It could be parakeratosis or other things that can cause that orangeophilic appearance. So moving on, you can have glandular abnormalities, which for me are always pretty tricky in cyto. So you can have reactive endocervical cells, which can have nuclear enlargement 4 to 5 times, and hyperchromasia, but round nuclei with smooth contours. So you can see these cells these nuclei are hyperchromatic, but they're very round and they have smooth contours versus what we were looking at earlier with HSIL that had the irregular nuclear contours. So really in cytology, what we're doing, it's all about the nucleus. Well, it's all about the cells in general, but the nucleus gives away a lot of information. You're looking at the hyperchromasia, you're looking at the nuclear membranes, etc. And in reactive endocervical cells, you can see prominent nucleoli. And be sure to look out for cilia, which could be indicative of tubal metaplasia. So for AIS, or endocervical adenocarcinoma in situ, you're going to want to think about feathering, like a bird's wing, which, as you can see here, this kind of looks like the wing of a bird with its feathers fanning out. And this is an example of AIS. So with AIS, we're going to see nuclear enlargement and crowding, cigar-like, think like a GI adenoma, like a TA or something like that. You're going to have high indice ratios with coarse dark chromatin, cellular crowding with rosettes and feathery edges. So you can see this feathering, or the cells could be arranged in a little rosette or a little circle also. I've seen that as well. You can have mitoses and apoptosis, and then typically no nucleoli. And AIS is most strongly associated with HPV-18, the subtype, HPV-18. Moving on to adenocarcinoma. It can be variable, but depending on the site of origin or the type. So generally, adenocarcinoma is more pleomorphic or irregular, and it'll have endometrial cell nuclei larger than an intermediate cell. Features suggestive of invasion are macronucleoli, tumor diathesis, increased single cells, and irregular chromatin. And then factors favoring endometrial adenocarcinoma versus endocervix are neutrophils, less cytoplasm, and smaller nuclei. Practically speaking, often diagnosed as simply atypical glandular cells using the Bethesda system unless very pleomorphic. So the category atypical glandular cells is going to be something that is commonly used, and at my level of training, I would have to defer that to my staff and consult with them and to get the best diagnosis for the patient. But just remember that these glandular abnormalities are not always straightforward, and it's just something to study, become aware of, and definitely don't be afraid to ask for help if you're not sure. Moving on, we have squamous metaplasia. So you can have thick, dense cytoplasm, as you see here, very dark teal, sharply defined cell borders, round, usually central nuclei with a normal nuclear size. And if you see squamous metaplasia, that can count as sampling of the transition zone, as we discussed earlier. Moving on, another can be tricky category is reparative or inflammatory changes. So in classic repair, you're going to have enlarged nuclei with prominent nucleoli, round nuclear contours with fine pale chromatin, normal indice ratios but variably sized, and then cohesive flat sheets with streaming like pulled taffy. And then you can also see background inflammation. So the prominent nucleoli is kind of what tips me off here that this could be repair. And then also if you look at the chromatin, it is not very hyperchromatic. It's pretty fine, which at least makes me feel comfortable that it's probably not dysplastic, or it's probably not necessarily anything malignant. At least that's how, in my mind, I think about it. If the chromatin is more clear, then I'm a little bit less worried. Moving on, we have general inflammatory change. So in general inflammatory change, you can see mild nuclear enlargement with fine pale chromatin, and they often have nucleoli. And you can see perinuclear clearing like this, but smaller and more even than coilocytic halos. So with that perinuclear clearing, I remember last week I just had a professor teach us that, well, we were looking at a pap that was just covered with trichomonas, and some of the areas had a lot of this perinuclear clearing, and he was just saying that if you see that, you may want to look out for potentially that there could be an organism like trichomonas or some other organism on the pap. And that makes sense, right? So if you're seeing this perinuclear clearing and that's associated with inflammation, you're going to have more inflammation if you see more, if you're having organisms in the pap smear. So just piecing that all together, it's one of the many reasons that I love pathology. It's just interesting, and you're able to think through these disease processes. So next up, we've got atrophy. So atrophy, as we're all familiar with, can be seen in low estrogen states. So that's postmenopausal, postpartum, premenarche, and Turner syndrome. So these are all instances where estrogen is going to be lower, and you're having changes in your hormone levels, either based on something physiological that just happened, or an aging process, or something you're born with or genetically predisposed to. So in atrophy, as I mentioned earlier, you're going to see a predominance of basal and parabasal cells that are going to have those high indice ratios, and it can be prone to injury, and there's often inflammation. So those basal and parabasal cells can be scary. Like I mentioned, they have that high indice ratio, but always take into account your clinical histories and be mindful of, is this patient in a low estrogen state? And that can clue you in that you could potentially be dealing with atrophy. So in atrophy, you have immature cells that can mimic HSIL, but as I mentioned, they're going to have a finely granular chromatin. So the chromatin is the key, it gives it away, and they're going to have smooth nuclear contours. So nothing about this image up here is that scary to me that I'm thinking, oh wow, this is probably dysplastic. You have very, very fine chromatin. The nuclear contours are totally like regular, or very similar to one another, and they're not really jagged or irregular as we saw with HSIL or other dysplastic processes. So in atrophy, you can see blue blobs as seen over here, and you can have granular debris that can mimic tumor diathesis, but no karyohectic nuclear debris. So again, atrophy has a couple things that can be a little worrisome, right? We have our granular debris that can mimic tumor diathesis, and we also can have our basal and parabasal cells that look like HSIL. So always think it through, take into account the clinical history. So this one is one that seems to show up often on tests, or I get asked about it a lot. So radiation changes. So as we're aware with in other systems as well in pathology, radiation can be damaging to cells, right? So it's going to cause a lot of abnormalities and just kind of bizarre changes. So you can have cytomegaly, or big cells with big nuclei, and the proportion of N to C, the nuclear to cytoplasmic ratio, is maintained. And you can have these large, bizarre cells. And that just, like I said, it just makes sense. So if you're radiating a cell, you're introducing this external radiation that is just completely abnormal, and the cell just reacts bizarrely, right? It's just behaving in a bizarre way. So you have this cytoplasmic vacuolation and polychromasia, and then multinucleation also. Moving on. Next up, we've got follicular cervicitis. So in follicular cervicitis, you can have abundant lymphocytes with a small rim of cytoplasm around the round nucleus, unlike HSIL, which is irregular. And you can also have numerous tingible body macrophages and variably sized lymphocytes with plasma cells. So as the name would suggest, cervicitis, this is an inflammatory process, so you're having a lot of plasma cells, lymphocytes, it's more of a reaction. Next up, you have the IUD effect, or the intrauterine device effect. And this is similar to radiation changes in my mind. You're having these vacuolated cytoplasm or bizarre changes. So the two characteristic findings for IUD effect, you have cells with abundant vacuolated cytoplasm, and then cells with dark, very small dark nuclei and scant cytoplasm that mimics HSIL. So always take into account the history to see if the patient has an IUD, or to see if the patient recently has undergone radiation for another malignancy, perhaps, or for a malignancy. So always be mindful of your patient's history in general, but especially with PAPs. So herpes, the classic 3 M's, right? So you have molding of the nuclei, multinucleation, margination of chromatin. So you have nuclear molding, multinucleation, and the chromatin is going to be marginated to the margins. And you have ground glass chromatin with eosinophilic nuclear inclusions. And you can obviously treat this with acyclovir. So you can have a shift in flora. And when that occurs, we have the classic clue cells, which are squamous cells covered with shaggy bacilli and mixed bacteria rather than the normal lactobacilli. So lactobacilli is what primarily composes the normal flora in the vaginal tract. And whenever that pH is altered, you can get overgrowth of different species of bacteria other than lactobacilli, such as Gardnerella vaginalis most commonly, that can lead to what are called clue cells, which are essentially just cells covered in bacteria. And this can lead to a thick, milky vaginal discharge with a foul, fishy odor, also known as the positive whiff test after adding potassium hydroxide. And this can be treated if the patient is symptomatic. Another organism, so Trichomonas vaginalis, is a pear-shaped protozoan STD with a pale, eccentric, elongated nucleus and red cytoplasmic granules. So here the arrows were pointing to Trichomonas vaginalis, and I've heard it referred to as a trichnic or a trick party, or if there's enough of them, even a trick conference. One of my colleagues said that the other day, and I thought that was pretty funny. Well, of course, not funny for the patient, and this can easily be treated with antibiotics, but I thought the reference was funny. Trichomonas vaginalis is often associated with leptothrix, which is a non-pathogenic filamentous bacterium. So that's a very testable thing. You have Trichomonas everywhere, and it can see what other organism may be associated with this, and you're going to say leptothrix, and you're going to get it right, and you're going to move on. And as I mentioned earlier, Trichomonas can commonly be associated with acute inflammation and inflammatory halos. Another organism, we've got Candida. So we've got a fungal Candida, as we are all familiar with, has a fungal species that can cause infectious disease throughout the gyne tract and other areas, thick cottage cheese discharge with eosinophilic yeast forms and pseudohyphae and hyphae. So they have this spaghetti and meatballs look, often tangled or skewering squamous cells. So I've heard that referred to as a shish kebab, where you can have these hyphae and pseudohyphae with squamous cells that have kind of been pierced by them, so it looks like what you would imagine a shish kebab that you put over the fire and then eat. So this would be a Candida shish kebab of squamous cells. And you usually only treat if the patient is symptomatic. And again, those inflammatory halos, that's a common theme that we're seeing, right? So if there's inflammation, you have the inflammatory halos, associate that with either trick or Candida, some other bug, could be in the area, so be on the lookout. Next up, we have actinomyces, which is a gram-positive anaerobic bacteria commonly associated with IUDs or other foreign bodies. So it's a long filamentous organism, tangled clumps of bacteria that look like cotton balls or dust bunnies, as we see here in this image. So no need to remove the IUD or to even treat it if they're asymptomatic. Next up, so we've got a slide on general management, and as a pathology resident, I don't necessarily tell the patient exactly how to get management, but I guess it's good to be aware of for testing purposes, and it's good to be aware of to know that the diagnoses that we're making as pathology residents or as staff pathologists, they really matter, and they're making an impact on how often these patients are followed up. So I'll let you review those on your own, but I will, I guess, just point out a few. So for a diagnosis of ascus, you're going to reflex to HPV testing. And then if that's positive, HPV testing, that's typically going to lead to colposcopy. And if it's negative, you just return to routine testing. Similarly, for ASC-H, L-SIL, or H-SIL, you're kind of going to be leaning more towards colposcopy, or if it's H-SIL, maybe even directly to a LEEP procedure. So again, just be familiar with these treatment algorithms. I'm not going to go through all of them, but just kind of refresh on those for your own education or for testing purposes, and just be mindful and just remember that what you're seeing under the scope and what you report does make a difference in the management of those patients. And then screening recommendations according to the USPSTF. So women 21 to 65 can have cytological evaluation alone every 3 years, or women from age 30 to 65 can have co-testing, which is pap smear or cytology, plus HPV testing every 5 years. So the most important, I guess, the center focus organism when you're thinking of pap smears and what we're doing when we're doing a pap smear, we're looking for dysplasia or what could be potentially cancer at some point. And we're thinking mostly about HPV, right? Human papillomavirus, which is an STD with a circular double-stranded DNA virus. And HPV is going to infect that transformation zone. And it establishes itself and replicates in the basal cells in particular. And it's detected in the vast majority of cervical cancers. And something we're familiar with from medical school, but the viral genes responsible for transforming host cells by integrating into the host DNA and disrupting tumor suppressor genes are E6 and E7. And E6 inactivates P53, which blocks apoptosis, and then E7 inactivates RB or retinoblastoma and gets rid of cell cycle arrest and leading to uncontrolled growth. And if anyone used Sketchy Micro, for me, I always remember the E7 inactivates RB because there was the root beer on the table with the straw shaped like a 7. So that's just how I remember it. And then, however, many infections are naturally cleared, so only a minority persist and lead to cancer. So typically, or very commonly, the patient's immune system will clear the infection on their own. So if they have HPV, that doesn't necessarily mean that it's always going to lead to cancer, obviously. Hopefully, and most commonly, the patient's immune system will just clear it on their own. So the high-risk HPV subtypes to be aware of, we've got 16, 18, 31, and 33. And those are the subtypes associated with cervical cancer and H-SIL, but can also cause L-SIL. Type 16 is most commonly detected in cervical cancers, and then type 18 is associated with endocervical adenocarcinoma, or as I mentioned earlier, AIS is associated most commonly with high-risk HPV subtype 18. And then, of course, there's the low risk, 6, 11, 42, and 43. And I always think of 6 and 11 because those are associated with condyloma, condylomas. And that's it. So just a 30-minute review of cervical cytology. I hope you enjoyed. I hope you got something out of it. I hope you enjoyed the sounds of the rain. And I hope you're as relaxed as I feel after that. But if you did enjoy, please like and subscribe. And thanks again to Kurt's Notes for allowing us to reference your material. And I learn a lot from these sessions myself when I make them, so I hope you enjoyed.